Thanks, David. It's a pleasure to be at the inaugural West Coast version of this conference. I've given the talk at the New York one, where they always seem to schedule me for 8 a.m., which is 5 a.m. my time, so I'd love being in my own time zone. So I'm going to talk today about the use of molecular genetic testing in MDS and MPN. It's actually a fairly broad topic and hard to do in just 20 minutes worth of time. So I'll focus on some of the highlights, mostly new things that have come up recently, or things that maybe not quite yet in common practice, but I think are going to be there soon. So these are my disclosures. So I'll start with what I consider to be the W's of genetic testing. This is really a call to consider context when you think about interpreting the genetic tests that you get on your patients, because the context really is going to be the defining aspect of how you interpret these studies. I'll talk about diagnostic use of mutations, how to refine prognostic risk with mutations, and then finally whether we can actually predict response to therapy or maybe even monitor response to therapy using molecular information. And I'll do it first for the myeloproliferative neoplasms and then for the myelodysplastic syndromes. So what I mean by the W's of testing is think about who you're testing. It really depends on what your pretest probability is, how you interpret that test. If you do a study on a patient who has got a normal hemoglobin and you get a JAK2 mutation, as I'll show you, that doesn't necessarily mean that a patient has a disease. And think about where you're sending your testing. If you're testing single genes, you are going to get back limited information. Are you looking just for hotspots? Are you sequencing the entire gene? Are you looking for a broad panel of genes? And I'll make the case that looking at a broad panel of genes can add information in several cases. And finally, think about the sensitivity. There are some diseases where small clones matter, particularly when you're thinking about prognostication. If you find a small clone that happens to be an adverse mutation, that might be something to note. That might be something that really changes the outcome for this individual. And if you're doing less sensitive testing, you might not identify that. Also think about the disease that you're expecting. One of the advantages of doing broad panels is that sometimes you get surprised, that you actually change what you think the patient might actually have based on the findings. And finally, think about when you're testing, because there are certain stages during disease course that can be amenable to genetic testing where you can learn different things. Are you doing this at diagnosis? Are you doing it primarily for prognosis? This may determine what kinds of panels you're interested in looking at, and again, how you interpret those genetic mutations. So I'll start with the myeloproliferative neoplasms. I'm going to skip CML because I think that's one that's been covered already today and one that we have a lot of familiarity using genetic testing for that one. But there are a lot of parallels with the other MPNs. And in particular, the WHO does a very good job of describing the mutations that are part of the diagnostic criteria for these disorders. And the reason that these are such good diagnostic markers is that they have very strong associations with phenotype. That if you have the right clinical context and you find the right somatic mutation, you are very confident that you've made the right diagnosis. So whether it be CML and BCR-ABL1, CNL and CSF3R, polycythemia vera, essential thrombocythemia, or primary myelofibrosis, the right mutation in the right clinical context is very strong evidence of the disease. And I'll show you later that's not exactly true for MDS. So each one of these disorders has genetic mutations that are strongly associated with it. And I think the default, the standard of care now, is to look for these mutations, whether it be a single gene test or as part of a larger panel. However, I will point out that having a mutation is not synonymous with having the disease. Again, this is another example of where context matters. And I would just want to share with you this really interesting study that was put out by Jason Gottlieb's group a couple of years ago, where they noticed that the 23andMe test, this is where you spit in a cup and you send it to the company and they tell you all about your ancestry, it happened to cover the JAK2 V16F somatic mutation. It had been included in a list of SNPs somewhere. And you could detect it, even if it was mutated in the blood, by sequencing the saliva. So just to prove this, they sent out these kits to a bunch of patients who had myeloproliferative neoplasms, some of which were JAK2 mutant and some of which were not. And you can see that the JAK2 mutation was pretty readily detectable in those patients who thought were JAK2 mutant. And then they looked at the greater population of patients that had sent their 23andMe test in, who had no idea whether they had any blood disorder at all. And they found that as you looked at older and older individuals, you can find a greater and greater incidence of the JAK2 mutation in the general population. And in fact, it wasn't an insignificant number. It was 0.2% of the general population, which is much greater than the actual incidence of things like polycythemia vera. So the mutations themselves are not diagnostic unless they're in the right context. If you have a patient in whom you don't suspect the disease, don't get the test, because if you find the mutation, it may not really have any meaning. So what else can we do with these mutations in myeloproliferative neoplasms? Well, it turns out, for example, if you look at things like myelofibrosis, they have very strong prognostic value. That here's a study from several years ago that looked at the relative importance of things like CALR mutations versus JAK2 mutations versus MPL mutations versus having no mutations whatsoever. And you can find that there's very strong differences in survival. You can even look at different kinds of CALR mutations that have strong differences in survival. And this has led to the development of very efficient testing algorithms that I actually don't agree with. I think back then this made sense that you would start with the most likely gene, JAK2, you sequence it, you don't find a mutation, you go on to sequence CALR, the next most likely gene in these diseases, you don't find a mutation, then you finally test MPL, which is the rarest one, and if you find a mutation anywhere along that length, you stop. And while that is efficient and cost effective, I don't know that we worry that much about cost effectiveness, but it ignores a lot of the other things that can be found if you do a broader panel of genes. And if you're worried about time efficiency, obviously that takes a little bit longer. So this is a study that came out around the same time that identified a multitude of other mutations that can be found in these disorders. And you'll see that especially disorders like myeloproliferative neoplasms have a high frequency of having additional mutations. Nearly half of the patients had more than just the disease-defining driver mutation. Now, there's an analogy for this where we can take a large number of patients with a disease, study their molecular genetics, and then use that to classify the patients, as opposed to what we're doing now, which is classify the patients based on diagnosis and then look for mutations. So Elie Papon-Monel did this in AML a few years ago, looking at thousands of patients with this disease, looking at their genetics, and found that you could cluster based on the molecular findings into several different groups. And I'll point out a couple because they actually are relevant even outside of AML. And these are patients that have TP53 or aneuploidy, multiple chromosomal abnormalities. They tended to form their own group. Patients that had chromatin or spliceosome mutations, these are mutations that affect the epigenetic state of the cell. These tended to form their own group. And these patients had very significant differences in outcome. So patients, for example, that were in that TP53 aneuploidy group were the worst behaviors, chromatin spliceosome mutations didn't do much better. So these are subsets of patients that were defined by their genomics, and we worried less about their actual clinical presentation and their phenotype, and yet we found these very strong differences in overall survival. So with that in mind, there was a very recent paper published in the England Journal of Medicine that did exactly that, looking at myeloproliferative neoplasms. So they had a large cohort of patients that they sequenced broadly, in fact, and found mutations in many genes. The most common, not surprisingly, are JAK2 and CALR, followed by TET2, ASXL1, and DNMT3A. These are mutations that are part of what we think of as common clonal hematopoiesis in older individuals. And they looked at whether these mutations could define different subgroups of patients based on a variety of factors, including chromosomal abnormalities, somatic mutations, whether these mutations were homozygous. And they found, not surprisingly, that there were different patterns in different diseases. So if you first lumped patients into whether they had essential thrombocythemia, polycythemia vera, or myelofibrosis, you could find different patterns, with ET being having the lowest mutation burden, regardless of what primary driver mutation it has, and myelofibrosis having the greatest mutation burden. And they recapitulated something that we all understand now as well, that polycythemia vera patients either have JAK2 mutations or they have nothing. They don't tend to have CALR mutations or mutations in MPL. Interestingly, they didn't sequence hotspots of these driver genes. They sequenced the entire genes, and they found several patients who did have mutations outside of the hotspot regions that they believed were functional. So there can be a greater diversity of mutations even in the known driver genes, and there may be some advantage to looking more broadly to catch those rare cases. So what they did is they came up with a very similar structure to the myeloproliferative neoplasms, where the first group that broke off was those patients that had TP53 or aneuploidy, just like in that AML study. And not surprisingly, these patients, while rare, did very poorly. Their overall survival was measured in just a couple of years. The next group that broke off are those myeloproliferative neoplasms that have chromatin or spliceosome modifications, the same category of patients that were identified in that AML study. And these patients were, again, primarily myelofibrosis, but also patients with PV and ET could fall into this category. And their survival was also substantially worse than some of the other categories, although much better than that TP53 mutant group. Finally, there was some distinction between patients who had different driver mutations, and interestingly, there was also a distinction between those patients that had homozygous JAK2 mutations. It seems that homozygous JAK2 mutations are enriched in patients with polycythemia vera and to some extent in myelofibrosis, but they don't necessarily portend a worse outcome. It's slightly worse when you think about overall survival and AML progression, but again, much better than some of those other conditions where they have those other mutations. So I think the future of these disorders and even myelodysplastic syndromes will be to take into account the mutations at a very early stage in the diagnostic process and actually maybe even build diagnostic categories around them and then go on to doing the prognosis as opposed to what we do now where we classify diseases, then ask if the mutations tell us anything more. So just to show you that those different disease entities, ET, PV, and MF, all had contributors to all of these different clusters. So it wasn't that defining the disease morphologically or clinically was the best way to start, that the mutations really could tell you something else about these individuals. But the things to keep in mind are P53 were bad players, and the more what I think of as MDS-like mutations, chromatin modifiers and spliceosome mutations, were also particularly bad players. So I'll say a couple of words about the MDS-MPN overlap disorders. I know Rami Kamrajki covered a lot of this earlier. But these disorders, actually this should be MDS-MPN, RST, are more highly mutated or have a higher incidence of mutations in a smaller number of genes. So they are, like he mentioned, a little bit more genetically homogeneous than myelodysplastic syndromes, for example. And in particular, I'll point out that in patients who have MDS-MPN, RST, SF3B1 mutations are very common, JAK2 mutations are very common, as are CALR. This really does look like the intersection of MDS and MPN. MDS with ring sideroblasts and essential thrombocythemia at the genetic level. But other diseases like CMML don't necessarily. They actually have a lot of mutations that are common in MDS, but they have an even higher frequency of some of these. TET2 is one of the most frequently mutated genes in CMML, and it occurs at about twice the rate as it does in MDS. And the same is true for ASXL1, SRSF2, and some of the other mutations. There's also a much higher incidence of RAS pathway mutations in CMML, particularly in the more proliferative subtypes of disease. Finally, for ACML, atypical CML, this can be a very hard disease to diagnose, but it also has a higher incidence of some of these same genes, particularly higher instances of SETBP1. Tends to be a little bit more specific for this disease at RAS mutations, but then again, the TET2, ASXL1, and SRSF2 show up again. They tend, when they are found together, be associated with more proliferative disorders like these. And finally, I'll point out that in juvenile myelomonocytic leukemia, some of the same mutations we can identify in the RAS pathways, but we don't see a lot of the chromatin modifying changes. And some of these mutations that we see in the RAS pathway can actually be germline. So I'll move on to myelodysplastic syndromes in the last bit of time that I have left. And I'll show you that same figure that I showed you before, and where you have very divergent phenotypes, and you have mutations that are strongly associated with those different phenotypes. It can be easier to use them as diagnostic elements. But in MDS, we have what I think of as a more convergent phenotype, where we have a commonality of bone marrow failure and a variety of different molecular pathways to get there. So this is analogous to randomly pulling parts out of your car. The likelihood is you're going to end up with a car that doesn't work, but you could probably do that 100 different ways, where there's probably only one way to make that car run better and faster. So this means that if you find a mutation in a patient you suspect has MDS, you may not necessarily be certain that that is the defining mutation or that is the diagnostic mutation. You're going to need more information. And part of that has to do with the fact that there's a lot of genetic overlap between MDS and these other diseases. And finding a mutation isn't necessarily going to tell you the patient has MDS versus having something else. Now, if we look at the WHO guidelines, there actually are genetic determinants of diagnosis in there. You can find the well-known del5q when isolated or with one other lesion not in chromosome 7. It can be diagnostic of the disease. And when you have mutations in SF3B1, this can also be diagnostic. And I'll show you that scenario. In the past, you needed more than 15% ring sideroblasts to define MDS with RS. But if you had less than that, then you would say the patient had idiopathic cytopenias of undetermined significance if they didn't have any other MDS defining criteria. Now you can sequence that patient for mutations, and if you find a typical mutation in SF3B1, then you can get away with as few as 5% ring sideroblasts. Now this sounds like it was designed by committee to some extent. Why 5%? And why only in that scenario? I think in the future we're going to expand the umbrella a little bit more and include patients that have somatic mutations that are typical of MDS in this category. Now that isn't to say that there aren't other genetic ways to define MDS. There's a list of chromosomal abnormalities that the WHO published that are so typical for MDS that you can consider them presumptive evidence of the disease if you find them. And they're listed here, things like monosomy 7, del5q, and so on. What we could imagine is that at some point in the future, there might be a list of mutations that do the same thing, but at the moment we don't have that, so I kind of blank that out, or I want you to write that down. Now, why can't we do that? Well, one possibility is the same explanation for why things like del20q and trisomy 8 are not on that list of MDS-defining chromosomal abnormalities. These lesions are not specific enough. We find them in other contexts, and they aren't necessarily disease-defining. We also don't include loss of chromosome Y in that list, and that's because this can happen in older individuals who actually don't have any disease whatsoever, so they have some degree of clonal hematopoiesis that has lost chromosome Y, but they aren't necessarily destined to have MDS. And the fact is that some of the genetic features that we find in MDS share both of these this lack of specificity, and therefore are not yet included in that list. But that isn't always the case, and I'll show you an example of that. So why is it that some of these mutations are not great markers of MDS? Well, for one, they can be found in some normal individuals. By now, you've likely heard about this concept of clonal hematopoiesis of indeterminate potential, known as CHIP, and how if you look at older and older individuals, you see a higher and higher incidence of the same types of mutations that you find in MDS and AML, mutations in DNMT3A, in TET2, ASXL1, in not insubstantial number of people, more like 15 to maybe 20 or 30%, depending on the age of the individual. Now, when you find it in patients who have normal blood counts, it looks a little bit different than when you find it in MDS. Well, first of all, it doesn't necessarily mean those patients are destined to get cancer. They have a higher rate of developing heme malignancy, which on a relative term looks large. It can be anywhere from 10 to 50 times greater, but in an absolute sense is actually very small. Most individuals who have clonal hematopoiesis defined by one of these common mutations don't go on to develop any disease whatsoever. Those that do tend to have a slightly greater abundance of mutation. This is the concept of the variant allele frequency, where the greater proportion of hematopoiesis that's defined by these mutations implies a slightly greater risk. But clearly you can see that a lot of the individuals that had very high variant allele frequencies did not go on to develop a hematologic malignancy. So this is, again, that concept of context, that if you're testing patients who you don't really suspect have MDS or something else, you may find things that may be hard to interpret, and you really shouldn't be testing those individuals in the first place. Now, what happens in those patients whom we do suspect have MDS? And we go through the standard diagnostic evaluation, and we don't find definitive evidence of the disease. There may be not enough dysplasia, there are no excess blasts, there are none of those chromosomal lesions that are defining of the disease. If we sequence those individuals on a broad panel of 40 genes or more, and we look for mutations that are present in at least 10% of the cells, what do we find? Well, it's about 40% of the individuals that will have a mutation. The 60% that don't have a very low rate of progression. They have a rate of progression that's about 10% after about 5 years of follow-up. Whereas those individuals that have one mutation have a 40% rate of progression to a frank malignancy. Those that have 2 or 3 have a 50 or even 70% rate of progression. And when you look at the types of mutations that contribute to that, it looks like that the chromatin modifying genes, the splicing factors, JAK2, or 2 or more mutations are at the greatest risk. Those mutations that are most common in CHIP, DNMT3A, TET2, or ASXL1, as single lesions are still associated with great risk, although slightly lower. But the take-home message from this is that those individuals that have cytopenias and no definitive evidence of MDS in the marrow, in whom you cannot find a mutation, their risk of progression is extremely low. It's about 1% per year. So I would argue that if you do a broad enough test and you come up with nothing, that you might be reassured about that patient. You may not know what they have necessarily, but you may be reassured that they aren't going to progress in short order. And you may want to rethink whether they might have a benign cause of their cytopenias that might be contributing to their clinical picture. So I'll summarize that in this slide, and in my minute and a half left, I want to talk about the prognostic use of mutations. So the IPSSR, extremely useful tool in MDS, and I consider it the gold standard for risk prognostication at the moment. However, it doesn't take into account the presence of somatic mutations, and we know that somatic mutations have prognostic value above and beyond what the IPSSR tells us. So how do we use them? So we've been involved in a very large study with the International Working Group for MDS. We're actually going to meet tomorrow in New York to discuss some newer data. But in this case, we looked at retrospective data from multiple centers around the world that shared a lot of clinical information and mutational information, and we asked a simple question. After taking into account the IPSSR, is there any additional prognostic information that mutations can show us? And if we look at all comers, we see that the presence of mutations in most genes are adverse. All 16 of these 17 genes, for each additional mutation that patients have, they do substantially worse. The one exception to that was SF3B1. patients who had a lone mutation in SF3B1 actually did better than even those MDS patients that had no detectable mutations in this panel of 17 genes. So SF3B1 patients may actually have a better than predicted prognosis. And we showed that a little bit more formally by doing these statistical volcano plots. And we broke it down by patients who have excess blasts. And we showed that even in these patients that we typically think of as higher risk, there are mutations that are associated with worse outcomes, and they're shown in this upper right-hand quadrant where the hazard ratio is greater than 1 and the significance is greater than 0.05. And for those individuals with less than 5% blasts, there's even more genes that are particularly prognostic in these patients who might predict greater than predicted risk. And they include, again, the splicing factors, chromatin modifying factors, RUNX1, TP53, and again, SF3B1 shows up as a favorable factor in this population. Just to show you the magnitude of that, it was more than a third of patients in this category who had one of these adverse mutations. And if we look at the more common of those mutations in this little cloud here that includes 9 genes, the presence of one or more of those genes diminishes the overall survival by a factor of 3. So compared to patients who had no mutations or mutations in just SF3B1. So it's a big factor. Even in patients who have a complex karyotype, another really adverse MDS prognostic feature, you can sequence those patients. Half will have a mutation in TP53, and those that do have a survival that's absolutely dismal, unfortunately. But those that don't, particularly those that only have 3 or 4 abnormalities, have a survival that's substantially better. It's compared 7.2 months for the P53 mutants to 31 months for those that don't have a mutation. So even in that high-risk mutation group or high-risk group, you can use mutations to refine risk stratification. So I'll skip the summary slide real quick and just talk about P53 in a couple other contexts where it's predictive of outcomes in the setting of transplantation. A very large study showed that TP53 mutations are associated with a very dismal outcome. Almost all of these patients actually relapse from their disease. And age doesn't seem to be a big factor if you have a TP53 mutation. There is some hope, though. There is some hint that maybe these patients are more sensitive to drugs like decitabine, particularly when given at high intensity, like they were in this study where they were given for 10 days out of 28 in each cycle. And by 4 cycles, every single patient in this particular study actually responded to treatment, even though they didn't necessarily live longer. That may still be an improvement for these patients who have a dismal outcome otherwise. So with that, I'll wrap up and happy to take any questions.